All right, let's do it.
Okay, you want just chief complaint or a whole HPI? I just have to figure out how to chunk out the case first.
I think chief complaint is a great place to start for sure.
Cool.
Yeah.
This is a 47-year-old man with type 2 diabetes, presenting chief complaint only with low-grade fevers.
All right. I think that's a great place to start. And I think, there's so many dimensions to reflect about fevers, but I think when it comes from, when it enters the world and you haven't verified it yet, you have to be cautious. There are a couple of reasons for that. Fever is an incredibly specific sign for inflammation. You ask yourself, how can I know somebody's inflamed? Well, the truth is there are multiple ways of inferring that a patient might be inflamed. You might come to that conclusion from a high white count, or you might come to that conclusion from a high platelet count, or actually a dropping albumin or weight loss. All of those things have a much wider differential diagnosis outside inflammation. So for example, a white count may be elevated because of the stress response of an acute myocardial infarction, which I saw yesterday. A high platelet count may be because of a myeloproliferative neoplasm without inflammation or reactive to iron deficiency anemia. A low albumin may be simply nutritional, though rare. But fever is very specific to inflammation. And so you can really invest all your cognitive energy in understanding the source of inflammation if a patient is in fact febrile. But here's the tension. No one has studied this as far as I know, but how often do low-grade fevers that are sensed at home translate into an objective temperature? And I'll tell you the answer is not 100%. So you really have to say, how confident am I is the patient febrile? And of course, if we get a measured fever at any point in time, that'll confirm the inflammation. If not, you have to hedge and kind of just stay focused on that possibility, but not committed to it. What are the most common mimickers of low-grade fevers? What really is stuff in the environment when patients are under more blankets than they usually are, when the thermostat is higher than it should be. There are a couple of endocrinopathies that tend to do it too. So hypoglycemia can mimic low-grade fevers by causing that reactive adrenergic drive, as can hypergonadotropic hypogonadism. So perimenopausal symptoms are certainly prominent for the hot flashes that are described, can certainly masquerade as low-grade fevers. If we do assume that the patient has a fever, which we probably should, that's where the now famous mnemonic of IMAID that Reza came up with, I think really applies. And the I stands for infection, the M for malignancy, the A for autoimmune, the D for drug, and E, the endocrinopathy. And I'll leave it at that for now. So I think the biggest takeaway is when you see the chief concern either on the triage board or on the piece of paper you're handed that says fevers, you're probably going to enter IMAID, but be sure that you're not committing a mistake in mimicking a non-inflammatory mimicker of fever, such as an endocrinopathy or environmental causes. All right, Rebecca, I'll give the mic back to you.
Awesome. And just to provide some context for this case, unlike most of my cases, this was actually an outpatient case. This is a patient that was presenting to clinic. So that gives you a little context. So patient reports that his symptoms started about 2 weeks ago, and he was measuring his temperatures up to as high as 99 Fahrenheit, nothing higher. My son wants to participate, I think. He also reports some intermittent palpitations over the last few weeks. Had one episode of loose stools, which has since resolved, and has had some sinus pressure as well. He's had no lightheadedness, no syncope. He tried cutting out caffeine because of his palpitations, which didn't help, but his exercise tolerance has been unchanged. He was able to walk about 30 blocks to clinic without issues, and his palpitations are better when he shows up in clinic today. No sick contacts. Comes in requesting Lyme testing, actually.
Well, hello, buddy.
Can you say hi? Hi.
How's it going?
He can't actually hear you. I have my headphones.
Oh, you have your headphones in. Oh, I didn't see that. Oh, well, thank you for a very rich HPI. I think there's the interesting dimension of this is it's very hard, it seems, for us to find any localizing symptoms. So you study this and you're like, there's palpitations And I will tell you, the vast majority of patients who report palpitations don't have any measurable arrhythmias. There's some extra cardiac phenomenon that leads to that sensation. So here it's probably tempting to say, hey, there's fever and palpitations. Is there something going on in the heart? And that may be true, but it may not be. One episode of loose stool, again, does that mean there's something going on in the GI tract? Maybe, maybe not. What about the sinus pressure? Again, I'd say that is fairly non-specific and doesn't necessarily land us in the sinuses. So I think here you're saying, oh, this patient has subacute sensation of fever, of fevers, but has no definitive hook to be able to attach their symptom complex to. So what would I do? I think you'd study the background medical history and the meds. And I think an exam might help you say, I didn't find anything on history to be able to say this is the source of inflammation. So let's see if any pathology rises to the surface that I can see with my eyes, detect with my hands or my stethoscope. All right, Rebecca, back to you.
Sorry, 1 second.
No worries at all.
We're having a battle of the wills here. Okay. So, let me just pull the note back up. In terms of his past medical history, as I mentioned, he has type 2 diabetes, which has been long-standing, does not use insulin at home. He has mild non-proliferative retinopathy, with macular edema. He also has a history of hyperlipidemia and fatty liver. Okay, you have to be quiet though. Sorry, guys.
Totally okay.
His home medications include Jardiance, which is sitagliptin, I think, 10 milligrams daily, rosuvastatin. You have to be quiet. Rosuvastatin, 10 milligrams daily. Jardiance must not be sitagliptin because he's also on Janumet, which is sitagliptin metformin combo. He only has an allergy to naproxen, and he has no significant surgical history. Social history, he's a professional, lives with his wife and kids in New York City, non-smoker, minimal social alcohol use, no IV drug use.
I love it. I think Ramla said it very well. Please don't apologize for being a mother and having at least 2 full-time jobs, probably more. And thank you for taking the time to present today, despite being in the midst of another full-time job. Really appreciate it. You don't need to apologize at all. We're all here just for the learning and the fun. So what do we learn? We've learned that the background is actually colored by the presence of diabetes. And I think that you certainly have to take the possibility of inflammation, namely infection, more seriously when your patient has diabetes, because the general rate of immunocompromise in patients with diabetes is certainly prominent. There are much more immunocompromising conditions than diabetes, but here the landscape is altered by the fact that there is an immunocompromising condition. And I'll just share with you briefly that actually it's not, the immunocompromising nature of diabetes is interesting. For example, there's not much more prominent viral infections in patients with diabetes, but there's a subset of very interesting infections that happen much more frequently in patients with diabetes. So we'll have to prioritize them. And those are, I'm sorry, I'm not sure what happened. Really are bacteria and fungi. The rate of superficial candidal infections in patients with diabetes is much higher. The rate of disseminated dimorphic fungi like cocci is much higher. And of course, the unique infection of mucormycosis, which is particularly emphasized in patients with hyperglycemia. On the bacterial side, the gram negatives predominate. And in fact, this week's New England Journal has an image that features this infection in a patient with diabetes. We talk about Pseudomonas and diabetes a lot. And if you're in South Asia or Southeast Asia, you'll reflect on the high burden of melioidosis in patients with diabetes. What I see most commonly is actually emphysematous urinary tract infections. The glucose in the urine allows bacteria to ferment and creating these pretty serious infections that can actually have a high rate of bacteremia, even with cystitis. And if you're getting real crazy, can actually cause air embolism and cause sudden death from this thing, which is crazy. The one gram-positive infection is you'll note there's a high rate of invasive group B strep infections in patients with diabetes. So what do we do here? I think these things, we have to see if they match the clinical syndrome, which is possible. You know, low-grade fevers without localization is certainly compatible with bacteremia from any of these things, or the less likely possibility that there's disseminated infection from one of these things. But what are we doing here? We're on the journey to understand the possibility of infection. And that, why are we in the world of infection? It's because fever, while not proven, is infection until proven otherwise. And here's the journey we all go on to. We start with recognizing that most people, when they have fever and they're coming to care, have some sort of viral infection, be it now in the pandemic, coronavirus, or in general, in outside of pandemic scenarios, all these viruses. Usually when we evaluate them, though, we don't assume it's a virus, and we wonder, is this patient who maybe is a little bit sicker have one of these 6 common causes of a bacterial infection: pneumonia, urinary cellulitis, cholangitis, C. diff, or bacteremia without a source. And this side here is usually the first pass eval. This is the base rate. Now, in clinical medicine, what we're all doing is we're taking the base rate, what's happened in the last 100 people. These things are probably like 95% of what's happened to the last 100 people who presented with fever. But we have to use the other variables that are unique to the patient. And the unique variable here is the patient has diabetes. So we're going to take these two schemas and try to marry them together, see what answer we find. But which one predominates? Which one is more important? Is this one more important, the base rate, or is the fact that the patient has diabetes? And I will tell you, base rate is queen. No matter what modifier you add, common things are still common. How do you know this? The most common infections in immunocompromised hosts are severe infections that affect immunocompetent hosts. For example, what is the most common cause of pneumonia in a patient with HIV? Strep pneumo, just like it is in a patient without HIV. What's the difference? The rate of bacteremia of Strep pneumo bacteremia goes from 1% or less in patients who are immunocompetent to about 20% in patients with more advanced HIVs. That's the only thing that changes. Not what infection, but how severe it is. So I'll pass the mic back to Rebecca and team to tell us more about the case.
Thanks, guys. Ezra has my phone now, so he should be appropriately distracted. Can you turn that down, please? So let's move on to his exam, I think, unless we're missing anything else. No, I think we're good. Okay, so in clinic that day, his temperature was 36.9 Celsius, 98.5 Fahrenheit. Blood pressure was 136/88. Pulse was 115, and O2 sat was 99% on room air. He was overall well appearing. He was alert, awake, didn't appear to be in any distress. His pupils were equally round and reactive to light. He had no lesions in his oropharynx. He had no evidence of proptosis or any other eye lesions. His thyroid was not enlarged, and he had no obvious nodules. He had no lymphadenopathy. I already mentioned no oropharyngeal exudates or edema, no lymphadenopathy in the cervical or supraclavicular region. Lungs were clear bilaterally. Heart was tachycardic, as explained, but with a regular rhythm, no arrhythmias noted on the physical exam, no murmurs. His extremities were warm and well perfused, good pulses, no edema. His abdomen was soft and non-tender, and he had a normal kind of general neurologic exam. So overall, a pretty unremarkable exam with the exception of his tachycardia.
Oh, wonderful. Thank you so much.
Sorry, really quick. I think I may have misspoken earlier. He has actually not neuropathy. He has some non-proliferative retinopathy as a complication of his diabetes. No neuropathy that we know of.
Wonderful, super helpful. By the way, folks, if you are interested in presenting a case in the future, you can watch how incredibly powerful the case presenter storytelling is. And you may not realize it, but like Rebecca clearly has a profound command of this patient, like what happened to this patient and internal medicine by how she's telling the story and giving us a lot to discuss here. So it's easy to go assume the heart rate is from sinus tachycardia at 115, but you want to get an EKG to make sure you're not dealing with the arrhythmia. And I'll share that when I think about sinus tachycardia, which we don't know here, I think of the 3 S's. Is this patient going to go in shock? And all the causes of shock, hypovolemic, obstructive, cardiogenic, is this patient going to evolve into shock? So that's one S. The other S is sympathetic toxicity. Now, what's the contrast between the shock and the sympathetic toxicity? All sinus tachycardia is mediated by an increase in adrenergic tone. And the question is the increase in adrenergic tone physiologic in response to either current or impending cardiovascular collapse, or is it actually pathologic increase in vasomotor or beta adrenergic tone? If you have a pulmonary embolism that's going to result in cardiogenic shock if you don't do something about it, you may show up with sinus tachycardia, but without a low blood pressure now. So how do you make the distinction between shock or sympathetic overdrive? And the truth is you don't know. But 2 weeks of sinus tachycardia, presumably 2 weeks, we don't know that, with a relatively normal-ish blood pressure makes me lean away from the shock or impending shock category to the sympathetic toxicity category. However, it's not uncommon for mild hypovolemia or a low-grade fever that has now resolved to cause this tachycardia. But what am I actually doing? I'm going to work up all the causes that could result in shock. This patient might need fluids. We're going to look for an infection for sure. But what I'm doing is pivoting early and looking for the easy ways to rule out sympathetic toxicity. What are the things that cause sympathetic toxicity? Well, they can either be exogenous things like cocaine, methamphetamine, certain medications causing serotonin syndrome, certain withdrawals from alcohol. It's a whole review that focuses on medications, toxins, and the eutox. A quick screen, looking at the medications here, there's nothing that should cause an increased adrenergic tone. Looking at the social history, there's no alcohol use, there's no benzo use to wonder about that. There's nothing to suggest serotonin syndrome. So the exogenous causes of sympathetic toxicity are much less likely. What are the endogenous causes? The most common in the ER is pain and anxiety. By far and away, sinus tachycardia, pain and anxiety, but the less common causes are the endocrinopathies. And the most common endocrinopathy is hyperthyroidism. So where am I at? This is what I do for everyone who has a fever on day 1. Have to prioritize this. But the specific context has led me to wonder not about hyperthermia, not about hematological issues, but about this possibility here. So I think it's important to do the workup that we did, focusing on viral infections, skin and soft tissue infections, which we don't see on exam, respiratory infections, which need an x-ray but don't see on exam, hepatobiliary infections, urinary tract infections, but also, in addition to the workup we talked about in the prior aliquot, I think this patient has enough data to suggest sympathetic toxicity that we might get a TSH. All right, back to you.
Okay, so his initial set of labs, he had a white blood cell count of 6.7 normal, as well as a normal hemoglobin of 15, normal platelets in the 200s, 277. He had a completely normal basic metabolic panel and hepatic function panel. He had a glucose of 125. Sorry, that was the only exception to his normal electrolytes. He had that Lyme disease that he had requested, that antibody with reflex Western blot was negative. He had a negative COVID swab, and he had an EKG that just showed sinus tachycardia. Do you want me to pause there, or do you want more data? I'm losing track of time here. Are we ready to?
We're totally okay. We have like 10 more minutes.
Oh, good.
But I'd say that this, we're going through our sequential steps of saying, wait, is this patient inflamed? As we talked about, we haven't gotten a fever yet. So is this patient inflamed? And there's more and more data to say maybe not. Normal temperature here, normal white count, normal platelet count, no anemia of chronic disease. So we're starting to move to the mimickers of inflammation, which again were environmental causes and endocrinopathies. So I think, we should round up the infection workup we should consider running up the infection workup, though you may be confident based on the normal O2 sat, normal lung exam, not even to get an x-ray. But I think we're starting to pivot from inflammation to inflammation mimickers and using our two S's. By the way, sorry, I misspoke earlier. It's the two S's, shock and sympathetic toxicity. And the last one is a fever. It's not, it's three things, but two S's. A fever can cause sinus tachycardia that goes away. So yeah, that's where I'd be at. Is what should we round up the infection workup, and what's the TSH?
Excellent. We had no additional infectious workup based on what you suggested, and I was hoping to stretch this case to 30 minutes, but I think 22 is going to be the way to go. Anyone want to take bets on his TSH? Throw your guesses in the chat. Excellent. So his TSH was below the level of assay at less than 0.008 in our lab. And his free T4 level was 8.0, and the reference range on our lab is 0.9 to 1.8 nanograms per deciliter. So you guys nailed it from the very beginning. Thought this was more appropriate for a 30-minute case than an hour case, but it's the differential is great nonetheless.
I think, Rebecca, honestly, you could have easily stretched this out to an hour and had a much deeper dive conversation. But we have 8 minutes left, and I'd love. We actually have a lot of reflecting to do. I'd love for you to maybe. I'm going to ask Tiago, our endocrinology expert, if he's available to talk about once the TSH comes back, to share with us his approach and what other diagnostic tests may be pending for this patient to understand the cause of their thyrotoxicosis. But I'm curious, like in this case, I would say pretty hard. I can easily see a lot focusing at least for quite a bit on infection, and then sending the TSH. So what was this like for you to go through in real life, not the simulated looking for diagnostic esoteria VMR space that we're in?
Totally. So the thanks for the opportunity. So the context here, I actually saw the patient 2 weeks after his diagnosis, when his the treatment that had been started for his thyrotoxicosis wasn't controlling his symptoms sufficiently, and he ended up in our ER and getting admitted. But I think, Robbie, you bring up an amazing point, and it kind of helped me reflect on how in awe I am all the time of our colleagues in primary care. This was a patient who, yes, he has diabetes, but he's otherwise a very functional, very kind of healthy guy who kind of lives his life and is normal and doesn't kind of see his doctor that often, who shows up with these 2 weeks of symptoms. And I think, in a 15-minute primary care visit, trying to sort out, is he infected? What's going on, right? I think, he came in, and I think this happens a lot, where the patient came in with an idea of some of the testing that he wanted. He actually came in saying, I think I need a Lyme disease testing and a Holter monitor, was kind of what he walked in requesting. And I think for the primary care doctor to kind of work through this, and I think clearly kind of an expert clinician as you are, to be able to walk through in 15 minutes this PCP and say, yes, he's reporting these low-grade fevers, but he's not febrile here, he has no localizing signs of infection. And really, I think the anchor point here is the kind of almost isolated sinus tachycardia. The one episode of loose stools maybe can help kind of tip your scales a little bit, right? So hyperthyroidism more commonly associated, not with diarrhea per se, actually, but with hyperdefecation. So the stools don't have to be loose, but they tend to happen frequently. And so the doc actually thought to send the TSH on that initial set of labs. So with the CBC, the BMP, the LFTs, the Lyme, and the COVID, sent the TSH, which I thought was very astute. And I was quite impressed when I was reading through his chart as I was admitting him for his kind of refractory thyrotoxicosis symptoms. Someone in the chat asked about weight loss and diaphoresis. He did not report, diaphoresis, yes. He reported kind of one episode of drenching night sweats, and otherwise just these low-grade temps that I told you about. And he did not report weight loss, although I could go back in the chart and see if there was any objectively noted. I don't know. I mean, Tiago, I'm curious if you think kind of only 2 weeks of thyrotoxicosis is enough to cause weight loss. I'm sure if it's severe enough, you could. I can go back and look at the weight. So I think, again, that was kind of my main reflection from the case, is just once again being in complete awe of our primary care doctors who have the kind of one-time opportunity for a 15-minute visit to decide what they're sending, as opposed to us kind of spoiled inpatient doctors who, if I forget to send a test on Monday, I can send it on Tuesday and right my wrongs. So that was the the main reflection I had here, and I'll look for his weight trend while we hear from Tiago.
I absolutely, just to reinforce that, before we pass the mic to our expert, I completely agree with you. I think I'm in awe I'm in the same situation you are. I work in a place with high resources in the emergency room on the wards, and I love that reflection. Thank you so much for sharing it. I will also just add massive props to primary care. If you were in primary care, you are doing tremendous work, period. There's no other way. Thank you. Thank you again, Rebecca. All right, Tiago, are you available to share some insight into what you might do if you were getting this patient as a referral?
Oh yeah, I have nothing much to add, as you and Rebecca were amazing discussing this case. But the next step, I will take TRAB or TSI, because the most common cause is Graves' disease. And even with this thyroid that is not enlarged, I would look for it. And many times we can't, it's not easy to feel thyroid. If you don't feel thyroid very well, don't worry. I don't feel thyroid very well as well. So people like to say, let's use this tool, and we should use our hands, but it's not a very good source. So I would take TRAB and TSI, and the best exam is scintigraphy, but I would start with TRAB and TSI. And for patients with diabetes and infections, when they come in the outpatient setting, I mean, they are not so sick. It's not common to have infections unless you are seeing the infection, like diabetic foot infection. Then you can see the infection, and the person points out to the foot and say, "Oh, it's aching." But if you have a patient, so this case is a very standardized patient for thyrotoxicosis. If I had to build a case for thyrotoxicosis, this is the way I would build, because they have this kind of subtle symptoms, but they feel it. If you have hypothyroidism, it's very common for you not to feel anything and feel good. But if you have thyrotoxicosis, then you will feel something, and generally it's related to your heart. So you have, your heart is running and the temperature a little bit higher. So it's not common to have this kind of symptom, like the sign, like temperature. I don't know why he was measuring his temperature, but he was worried he could have another disease. But this is very common. I would say that for diabetes patients, for you to think about infection in the outpatient setting, it's very unlikely. So I cannot remember a patient that I saw with diabetes, and I have many patients with diabetes, complaining of an infection in the outpatient setting, unless it was in their foots. I think it's a great point here. And most likely it's Graves' disease. And for weight loss, they lose weight, but as Rebecca said, in 2 weeks, it's they can realize it, but they cannot realize it as well. So I would not take it so hard. But if he said, "I'm losing weight," then it would be another clue.
So I just went to the notes, and it looks like, actually, even though his symptoms began in mid-June, when you look at the objective trend of his weights, he actually lost almost 30 pounds between April and July. So it looks like there may have been some subtle weight loss. And he wasn't a big guy. He went from 160s to 130s. So actually, I'm surprised that he didn't identify that weight loss.
Yeah, they often lose weight, but thank you very much for bringing this case and for this amazing discussion, because as I said, it's a very classic case of thyrotoxicosis. This is the way they present, just saying, "I have intermittent palpitations, I don't feel very good, I'm losing weight." And another clue that you can have in the physical examination is the tremors. It helps a lot, because thyrotoxicosis patients, they have enhanced physiological tremor, and it's very common for them to present with it. So even if they don't complain, you can see. If you ask, just put your hands this way without support below, and then you can see it's like shaking.
Oh, incredible. Two people I deeply admire, Rebecca and Tiago, here, with walking us through such an incredibly informative case, and one in which the folks in real life did clinical reasoning on steroids and got this patient a diagnosis on their first visit, which I think is deeply admirable. If you were, I think we at the CPS office are being more and more transparent about how much we love our community and really thrive by our community, and also how we can be more transparent about ways you can support us to do our work. And it turns out that Well, Reza and I do a fair number of episodes. We do up to 5 episodes a month on Patreon. So if you Google CP Solvers and Patreon, it's a subscription model. But I share that today in part to let you know of ways that you can support us at the Clinical Problem Solvers. But more importantly, to tell you that the most recent case actually involves a very tricky case that is fairly atypical that may touch on the thyroid. So if you're on the fence about supporting the CP Solvers, this thyroid case may be good spaced learning for you. I'll put the link in the chat, but for those of you who are listening to this later on YouTube or later anywhere else, you can Google CP Solvers and Patreon, Patreon, and find a good thyroid case and think about ways you can support us in our mission to get diagnosis everywhere. All right, I'll have a wonderful Thursday. I will pass the mic to my dear friend Maria to round up the teaching points, and we'll bid you farewell.
This was amazing, completely changed my morning. We should do this every day at 6 a.m. But I'm gonna share some quick, really, I think the most important teaching points of the day. When you have fever that is very specific for inflammation, you can always look for other signs that the patient has inflammation, like high white blood cell count, high platelets, low albumin levels, but those are not very specific. They're mostly sensitive, but fever is a really good indicator for inflammation. And I think you always want to try to look for localizing features, but be cautious because not all palpitations mean heart, not all diarrhea means GI disease. And fever, although it leads to inflammation, it doesn't clue us into what can be causing this inflammation. So you can always use the IMate mnemonic to try to start thinking of causes of the inflammation. And it's very important that fever does not mean infection, but it's a good place to start. And when you're considering infection, start thinking of base rate infections. So first pass, think what happens to most people. And this is Queen. Common things are always common, no matter who the host is and what risk factors they have. So start considering viral infections first, and with a second pass, consider risk factors unique to the patient. So for example, this patient has diabetes, which makes them immunocompromised. And with diabetes, you always have to prioritize fungal and bacterial infections. And for this, you're going to want to look for signs of specific infections through the physical exam. So use your eyes, use your stethoscope, use your hands, and try to localize an infection. And if you can't, you can aid yourself with other testings. And in this patient who had a relatively unremarkable physical exam but had sinus tachycardia, consider 2S and 1F. Consider impending shock, and for that you want to have your eye on the blood pressure and look for causes of what might be causing a shock, because that's a do not miss diagnosis for sure. Also think of sympathetic toxicity and fever. In this case, vitals seem normal. There was no fever. And so we were narrowing down into sympathetic toxicity. And for that, you want to look for exogenous and endogenous causes. So exogenous, think of meds and some drugs. It didn't seem to be the case because the patient didn't have any sympathetic drug medications or didn't consume drugs. And then you want to look for endogenous causes. Most common pain and anxiety, especially in emergencies, but definitely second cause you want to look for is endocrinopathies. And for this one, the most important one is hyperthyroidism. So order TSH whenever you're thinking about it, because a lot of people have thyroid problems. That's just like in this case. That's it.
Thanks, everyone. I threw a quick case follow-up in the chat. We did send the thyroid binding immunoglobulin level, which was elevated. He was started on methimazole and atenolol, but as I mentioned, I met him in the hospital because unfortunately those meds didn't control his symptoms sufficiently. So after trying to titrate the meds, still with no success, he ended up getting radioactive iodine and is doing much better.
Amazing. Thank you all for the follow-up, and thank you for joining us. Have a great Thursday. Bye.